All right, so we're in chapter 28. In my last video, we talked about cranial nerves, which is really important to know. Now I'm going to cover some of the other important points in this chapter. So when you're assessing a patient's thyroid gland, it shouldn't be visible when you're just looking at them sitting or standing in front of you. If you want to better visualize the thyroid gland, you can have them hyperextend their neck. But also probably a better idea is to have them sip a glass of water, swallow. As they swallow, you can feel that thyroid gland move up, and you can kind of palpate it, make sure there's no lumps, make sure it's not enlarged, that type of thing. So now let's talk about inspection of the eyes, and specifically we'll talk about vision assessment. So you guys are probably familiar with the Snellen chart. That's the chart with the E, the big E at the top, and all the other letters. So the way you want to do this assessment with your patient is you want the patient to stand 20 feet away from the chart, and this helps us to determine if they have impaired far vision, which is myopia. So if the result of the Snellen chart comes back 20/40, this means that a patient needs to be 20 feet away from a letter that someone who has normal visual acuity can be 40 feet away from the letter and see it. So that's how you kind of interpret that 20/40. The other test you're going to want to do is the Rosenbaum eye chart. So this is testing for presbyopia, which is impaired near vision. So you're going to hold the chart 14 inches away from the patient to assess their near vision. And then lastly, we have the Ishihara test, which tests for color vision. So I would definitely be familiar with those three tests. So now let's talk about other eye assessment things we need to do. So we want to check for extraocular movement of the eyes. So there's a couple different tests that we do. One is the corneal light reflex test. This is where we shine a light in the patient's eyes and check for symmetry of the light on their corneas. Then we would do a cover-uncover test, which tests for strabismus, which is a term we use for misalignment of the eyes. So one eye is looking this way and one is maybe drifting in. They're not aligned. And then we can check their 6 cardinal gaze positions by having the patient kind of follow your finger as you make a big H in front of them. Another kind of mnemonic or word to help you with your assessment of the patient's eyes is PERRLA, PERRLA. So the P would stand for the pupils are clear, so they're not cloudy or anything like that. E means equal to 3 to 7 millimeters in diameter. So if they are smaller than that or bigger than that, it can mean different things. It can mean they're taking some medication or drugs which are causing that. It can also could indicate brain injury, some other things like that. So 3 to 7 millimeters is what we would expect. And then R stands for round, so they should be nice and round. RL stands for reactive to light. So when you bring a light over in front of their eyes, you should see that pupil constrict and the other one constrict at the same time. And then A stands for accommodation to near and far objects. So we would expect these things with the patient's pupils. PERRLA, so pupils clear, equal to 3 to 7 millimeters in diameter, round, reactive to light, and accommodating to near and far objects. So the other thing I would keep in mind is the artery-vein ratio. So if you were to use a ophthalmoscope to look into their eyes, you should see 2 arteries for every 3 veins. So it's a 2 to 3 ratio. So now let's talk about hearing assessment. So there are 3 tests that you should be familiar with. One is a whisper test. So this is where you would cover one of your patient's ears and whisper to them about 1 to 2 feet away without letting them see your mouth. We don't want them reading lips, and see if they can hear, and then kind of cover the other ear. Another test you should do is a Rinne test, which is where you hold a vibrating tuning fork against the mastoid bone and then in front of the ear canal. So this tests for conductive versus sensory neural hearing loss. And then we have a Weber test, which is where you hold a vibrating tuning fork on top of the patient's head to compare hearing on their left and right side. So, in terms of other things we need to assess for with the patient's ears, we should check the alignment of their ears. So, the top of the auricles should be at the same height as the inner canthus of the eyes. When you're putting an otoscope in a patient's ear, you want to pull the auricles up and back for adults, and you should pull it back and down for children under 3 years old. You should insert the otoscope only 1 to 1.5 centimeters into the ear canal, and you should not touch the ear canal. The tympanic membrane in the ear should appear pearly gray and intact. You should also see a light reflex. So the light reflex will be visible at 5 o'clock for the right ear and 7 o'clock for the left ear, and should be in a cone shape. And then cerumen is basically earwax, is an expected finding in the ear. If you have tons of earwax, it can affect hearing. But if you're given a question about, like, a nurse is looking the ear, sees these things, which of these are cause for concern, if there's some cerumen, that's totally okay. So now let's talk about some changes that happen as patients get older. So in older adults, we can expect them to have decreased vision. Yellowing of their lenses in their eyes is also very common, and patients also have issues with glare and darkness as they get older. As far as ears, hearing loss is really common, but you shouldn't just assume that they can't hear well. So I myself have been guilty of going in a patient's room and the patient's really old, and I just assume they can't hear well, and I'll come and start talking really loud, and they're like, "Can you keep it down? Like, you're hurting my ears." So that was a good wake-up call. After that, I'm really sensitive to that, and I make sure I'm not yelling at someone who has intact hearing. Also, we would expect thickening of the tympanic membrane. In terms of the patient's mouth, as they get older, they will have a decreased sense of taste. Gum disease is really common, as is tooth loss. Also, older adults have decreased salivation and paler gums. So it's not as red, it's more pale. In terms of their voice, increased vocal pitch often happens as patients get older. And then in terms of the nose, they often have decreased sense of smell. So that is it for this chapter, and we'll pick it up with another video. Thanks.